everyone. Here is today's specimen. And I'll play the video here before I put up our first polling question. Okay, so I'm going to put up our first polling question here. So what specimen is this? And then I'll end the polling there and share the results. So great job, everyone. It is, in fact, a subtotal gastrectomy specimen. So here's an image here just showing some of the different types of resections that we can get for stomachs. So with a subtotal gastrectomy specimen, this is the removal of about 70 to 80% of the distal stomach, whereas a total gastrectomy would remove the entire stomach, and then a wedge gastrectomy only removes a small portion of the stomach. A subtotal gastrectomy specimen is typically the treatment of choice for middle or distal third gastric cancers. So the stomach is a hollow muscular organ located between the esophagus and duodenum, the first part of the small intestine. The primary function is temporary storage of food. It also aids in food digestion through mechanical and chemical digestion by secreting digestive enzymes and gastric acid. So there's four main regions of the stomach. So the cardia, fundus, body, antrum/pylorus. So the cardia is where the contents of the esophagus empty into the stomach. The fundus is this upper curved portion. And then the body is this central region. The antrum is the distal portion of the stomach. And then the pylorus is composed of a muscular ring, which is the connection between the antrum and the duodenum. And the pyloric sphincter is what separates the stomach and the duodenum. Other important landmarks to identify are the lesser curvature seen here. So this is a short concave curve on the right side of the cardia to the pylorus. And this is where the lesser omentum would attach onto. And then the opposite side here, so this is the greater curvature, which is a longer convex curve on the left side of the cardia to the pylorus. And this is where the greater omentum would attach onto. So for our specimen today, just to orient you all, so this is our distal end here. And this is our proximal end, which has been oriented to us with a suture tie as well. This is our lesser curvature with our lesser omentum attached. And then our greater curvature here with the greater omentum attached. This region here is the body. And then the antrum and the pylorus. So for our specimen today, we do not have the cardia or the fundus because this is a subtotal gastrectomy specimen, so it would not include that. So now we'll go in to talk about the blood supply, and I'll put up our next polling question here. So where does the right gastric artery come off of? Okay, so I'm going to stop the polling there and share the results with everyone. Okay, so unfortunately, most people did not get this one correct. So we'll go through and describe this and break this down a little bit. So the arterial supply of the stomach comes from the celiac trunk and its branches. The celiac trunk originates from the abdominal aorta and gives off three major branches. These include the left gastric, common hepatic, and splenic. And then the proper hepatic is a continuation of the common hepatic here. And this then gives off the right gastric, which is shown here. So the correct answer to the polling question was the proper hepatic. So the lesser curvature of the stomach is supplied by the left and right gastric arteries. The greater curvature is supplied by the left and right gastroepiploic arteries. And now we'll go in to talk about a little bit more of the internal anatomy of the stomach. So there's 4 main layers of the stomach wall, which include the mucosa, submucosa, muscularis propria, and serosa. And this is going from inside out. And this will be really important when we talk about staging later. The mucosa and the submucosa contain longitudinal infolding known as rugae. And you can see that on this image here. So this rugae is coarser proximal and when the stomach is emptied. So just to orient you all with this photo here, so here's the esophagus going into the cardia, then the fundus, the body, the antrum, pylorus, pyloric sphincter, and then a small portion of the duodenum. So you can see that there's coarser rugal folding located within the body and fundus of the stomach versus in the antrum, that folding is a lot flatter. So within the mucosa is where the gastric glands are found, and these contain gastric cells. And I'll put up our next polling question here. So which of the following stomach cells releases peptinosin? Okay, so I'm going to end the polling there and share the results with everyone. Great job, everyone. It is chief cells. So the mucinous neck cells secrete mucin. The parietal cells secrete gastric acid or hydrochloric acid. The G cells are neuroendocrine cells, and they're responsible for the synthesis and secretion of gastrin. So now we'll move on into talking about how we open/fresh these specimens. So we want to first be starting by hinging our distal and proximal staple lines. So here you can see our distal staple line here, and then our proximal staple line here. And then we'll want to cut along the greater curvature. And then we want to pin out the specimen like shown here. And this is just a really good idea because otherwise the specimen will kind of fold back onto itself and fix kind of curled up. So taking sections in that state would be very difficult. This way we have a nice flat surface to take our sections. As well, you may notice that the color is a little bit different. So this specimen here is fresh. And then in this stage, it's after fixation. So the coloration is a bit more of a tan color. So as you may have guessed, our specimen today is out for gastric cancer. And I'm going to put up our next polling question here. So if a tumor is involving the gastroesophageal junction, what is the cutoff for the tumor to be classified as a gastric cancer versus an esophageal cancer? Okay, so I'm going to stop the polling there and share the results with you all. Yes, so the correct answer is B. So it's greater than 2 centimeters. So here's just an image just showing the differences between gastric versus esophageal cancer. So gastric cancer is carcinomas that are involving the gastroesophageal junction with a tumor midpoint greater than 2 centimeters into the proximal stomach. So that's shown with this image here. It can also be carcinomas of the cardia or proximal stomach without involvement of the GEJ, even if the tumor midpoint is less than or equal to 2 centimeters into the proximal stomach. So that would be shown with this image here. Versus with esophageal cancer, you can see that that midpoint is within that 2 centimeters, and then it is also involving that GEJ. So in Canada, it's estimated that in 2022, about 4,100 Canadians were diagnosed with stomach cancer. 2,000 Canadians died from stomach cancer, and the incidence rates are 2 to 3 times higher in men versus women. Worldwide, gastric cancer is the 5th highest incidence among cancers and the 3rd leading cause of cancer deaths. Incidence rates are highest in Eastern and Central Asia due to H. pylori prevalence and virulence, as well as dietary factors. And I'm going to put up our next polling question here. So which of the following is not a risk factor for developing gastric adenocarcinoma? Okay, so I'm going to stop the polling there and share the results with everyone. So it looks like there's a pretty close tie between B and D. So the correct answer is actually D. So NSAID use is not a risk factor for gastric adenocarcinoma. NSAIDs are a common risk factor for peptic ulcer disease of the stomach and duodenum. So gastric cancer, more than 90% of all gastric carcinomas are adenocarcinomas. The most common location is the insera angularis, which is a small notch of the stomach located on the lesser curvature near the pylorus. So you can see that here. Oftentimes, gastric cancer is broken down into either cardia or non-cardia gastric cancer. So cardia arises in the region adjoining the gastroesophageal junction, and then non-cardia is more common and arises in the lower portion of the stomach, and more than 90% of these cases are associated with H. pylori infection. In recent years, the incidence of non-cardia gastric cancer has decreased, while cardia and diffuse gastric cancer is on the rise. And this cause of the overall reduction of gastric cancer is most likely linked to the decrease of the H. pylori prevalence. So now we'll go into classifications for gastric cancer. So using the Lauren classification, so that breaks it down into either intestinal or diffuse type. So intestinal type is granular morphology. It's commonly associated with atrophic gastritis, gastric epithelial dysplasia, and the gross features for this type typically appear as an ulcer with heaped up edges or an exophytic or polyploid mass. So talking about diffuse type, I'm going to put up our next polling question here. So patients with a germline CDH1 mutation have a higher risk of developing which of the following malignancies? Okay, so I'm going to end the polling there and share the results with you all. So it looks like there's a tie between A and B, so the correct answer is actually B, lobular carcinoma of the breast. So for diffuse type, this is poorly differentiated signet ring cells. This type of carcinoma is typically associated with an aggressive behavior and poor prognosis. It can be seen in either sporadic or familial settings. However, a significant portion of these cases are seen in the context of hereditary diffuse gastric cancer syndrome, and mutations in CDH1 gene are commonly involved. Patients with hereditary diffuse gastric cancer caused by germline CDH1 mutations are also predisposed to lobular breast cancer. And the gross features for these typically, so for early stages, lesions may not be present. And then for more advanced stages, these lesions typically show thickened wall with or without ulceration, or linitis plastica, which is a leather water bottle-like stomach. So here are some gross images just showing those two different types. So intestinal type here you can see is an exophytic mass, versus with diffuse type you can see that the gastric wall is very thickened, and then the mucosa overlying is flat. Here's also an example of linitis plastica. So you can see that the entire stomach here is involved, and it has the appearance of a leather water bottle, like the one shown in this image here. So another way to classify gastric cancer is using the WHO classification. So this breaks it down into 4 main histological patterns. So tubular adenocarcinoma, which is the most common, papillary, mucinous, and then poorly cohesive carcinoma. And it can also be a mixed carcinoma as well. So a few differential diagnoses that we want to be considering when we get gastrectomy specimens would include gastric lymphoma, GIST, and then peptic ulcer disease as well. So now we'll go into each one of those categories. So with gastric lymphoma, about 55 to 75% of primary GI lymphomas are gastric. 1 to 7% of gastric malignancies are gastric lymphoma. And the stomach is the most common site of MALT lymphoma. And MALT lymphoma is commonly associated with gastritis caused by H. pylori infection. These patients are typically older, with the age being 60 plus. And for gross features, these masses are large, polypoid, lobulated masses with superficial or deep ulceration. And then they typically have a gray or white cut surface. So you can see here with this large ulcerated mass, and then the cut surface here being more of a white-gray appearance. So our next one that we'll talk about is GIST, so gastrointestinal stromal tumors. So this is the most common mesenchymal tumor of the GI tract. It arises from the interstitial cells of Cajal in the myenteric plexus of the muscularis propria. And the most common location is the stomach. Most are due to mutations in proto-oncogene KIT. And so for gross features for these, they're typically well circumscribed within the muscularis propria. So if you have a lesion that's more like on the mucosa or submucosa, then most likely it's not a GIST, versus if one is centrally located within the muscularis propria, that's more likely going to be a GIST. The cut surface is fleshy, tan pink, and can show areas of hemorrhage or cystic degeneration. So here you can see the mass here with the mucosa over it. And this is the cut surface here, which you can see is very tan with some cystic areas. And I'm going to put up our next polling question here. So the Carney triad is a rare syndrome defined by the coexistence of which 3 tumors? Okay, and I'm going to end the polling there and share the results. So the correct answer for this one is A, so it is GIST, pulmonary chondroma, and paraganglioma. So now for peptic ulcer disease. So the causes of this is mucosal injury due to H. pylori infection, NSAID use, like we said earlier, Zollinger-Ellison syndrome, and the incidence in the US is about 3,050 new cases per year. Usually they're located within the antrum along the lesser curvature, and they're more common in the duodenum versus the stomach, about 4 times more common. And we typically don't see specimens for just peptic ulcer disease anymore because the oral treatment for this is very good now. However, we still want to be able to identify some different gross features between these two. So for gastric ulcers, they're sharply punched out with radiating mucosal folds. So you can see these radiating folds here. They have a smooth base with flat edges. Versus with a carcinoma, you have an irregular bordered area, and then with distorted or flattened rugal folding, and then a hemorrhagic and necrotic base, and then raised edges. So for our specimen today, after we've gone through all of those different types of differential diagnoses, so the pathology for our case came back as adenocarcinoma, poorly cohesive. So now we'll go into talking about the grossing steps for these gastrectomy specimens. So we'll want to identify what the specimen is, talk about the main findings, additional findings, ink code, and section code. So what our specimen is. So we already mentioned that it is a subtotal gastrectomy specimen. So we'll want to be giving a measurement of the stomach along the greater curvature, and then along the lesser curvature, and then as well a measurement of the open circumference. And this can be either arranged between the smallest open circumference and largest open circumference, or just the average open circumference. We'll also be wanting to measure the greater and lesser omentum. So we'll give that measurement in depth, so where it inserts onto the stomach, and then where the surgeon had to resect the tissue. If we had a portion of esophagus or duodenum, then we'd also be wanting to measure that and mention it as well. So our main findings will be describing the lesion, so that would include the size, location, and margins. So for location, we'll want to identify what part of the stomach it's located in, so the cardia, fundus, body, antrum, or pylorus. And in our case, it's located within the body. We'd also need to indicate whether it's on the anterior wall, posterior wall, lesser curvature, or greater curvature. And for our case here, it's on the posterior wall. And then we'd be giving distances to margins. So our proximal margin here, and then our distal margin here. We'd also be giving a measurement to our radial margin, which would be our omental margin. And then if we had multiple lesions, we'd be giving the relationship between those, including the distances. So here's a video here just showing the radial margin for our specimen. So it would be the lesser curvature here, and it would be this whole area that's not covered with serosa, all the way up to these vascular ties here. So you can see there's no serosa covering that area, versus on the side here, you can see this glistening area. So this would be the serosa. So that area would not be our radial margin. Just that top layer where my finger is would be the radial margin. And then as well, you can see a few lymph nodes in that lesser omentum as well here. So our additional findings will be to describe the non-involved mucosa, and then also describing the lymph nodes. So we'll want to describe the number, appearance, and location, so whether they're located in the lesser omentum or greater omentum. And then I'll put up our next polling question here. So what is the minimum number of lymph nodes that needs to be assessed for a gastrectomy specimen? Okay, so I'm going to end the polling there and share the results with everyone. So it looks like there is a tie between A and D. The correct answer is actually D, 16 lymph nodes. I could see where people picked 12 because that is the minimum number for colorectal cancers. But for gastrectomy cases and gastric cancers, we need to find a minimum of 16. So if you don't find that minimum of 16, it's a good idea then to be submitting sections of the fat. And usually with these specimens, we don't actually get too much fat with the lesser and greater omentum. So it is possible to just submit all of the fat if you're having a really hard time finding those lymph nodes. So our ink code for our institution, so we do black for the radial margin. So you can see here that I've inked all of that non-serosalized surface, all black, so that would be my radial margin. and then green for the proximal end, and then orange for the distal end, and then blue for the serosa overlying the mass. So we don't need to ink the entire serosa, just the area that's overlying the mass here. For section-wise, so we'll want to do our proximal and distal end resections. So we'll submit those on FAST if the mass is greater than 2 centimeters from the margin. However, if the mass is closer to the margin, then we want to be doing perpendicular sections. And that's shown with this image here. Since our mass is pretty close to that proximal margin, we want to be doing perpendicular sections so that we can get a good measurement of how far that tumor is from that proximal end. For our sections of the mass, we'll be giving 1 section per greatest dimension of the mass. Unless the mass is very small, then we can submit it entirely. Our sections to include will be the maximum depth of invasion, closest serosa, closest radial margin, and then mass with adjacent uninvolved mucosa. So here's just a video here just showing how I section the mass. So I want to section all the way through the mass so I can see its involvement with the serosa, as well as its involvement with the greater and lesser omentum and the radial margin. So here are some of the sections laid out, and just to orient you all, so here's the greater omentum here. And then on this side is the lesser omentum with that radial margin that you can see the black ink there. And then all of this blue ink that you're seeing is the serosa. So the mass is this large white area here with this central ulceration. And then here's a bit of the normal mucosa. So continuing on with our section, so we'll also be wanting to submit uninvolved gastric mucosa. And it's really important to do this specifically for gastric neoplasms because they may invade extensively beyond the normal appearing mucosa. So we'll want to give a section within the body, within the antrum, and then also within the pylorus. If we had any additional findings, so any other ulcers or polyps, we'd be wanting to submit those. And if we had any other attached organs, we'd also be wanting to take sections. We want to submit all of our lymph nodes that we found, and we'll separate those into lesser curvature and greater curvature lymph nodes. So here is a sample gross description of the subtotal gastrectomy specimen. So I said that the specimen consists of a subtotal gastrectomy specimen, then I give all of its measurements. So the measurements of the stomach, and then with the attached lesser omentum, attached greater omentum, and then the orientation. So the specimen has been oriented as per requisition with suture marking proximal end. Our main findings paragraph will be talking about the mass. So there is a white, firm, ulcerated mass located within the body of the stomach on the posterior wall. And then the mass measurements to all those margins that we mentioned. And then I say that the mass possibly extends into the lesser omental soft tissue. And the overlying serosa is white, nodular, and possibly involved by the mass. My additional findings paragraph will be talking about the uninvolved serosa and mucosa. So the remaining serosa is tan and glistening. The remaining gastric mucosa is grossly unremarkable with no additional lesions grossly identified. And then I'd also be talking about my lymph nodes. I also state my ink code here. And then here is my section code. So I did representative sections. For this case, frozen sections were completed, so I put those all in the first cassettes. And then I went on and did the mass with proximal end, and then the distal end resection margin on fast, and then the mass with extension into the lesser omental soft tissue, then mass with closest radial margin, and I indicated that I submitted the closest radial margin entirely. Then I put in the mass with the white nodular serosa, mass with adjacent greater omentum, mass with uninvolved mucosa, and then the vascular tie margin from the lesser omentum, my uninvolved mucosa, and then my lymph nodes entirely. And again, I indicated which ones were from the greater omentum versus which ones were from the lesser omentum. So now we'll go into talking about staging, and I'll put up our next polling question here. So what PT stage is a gastric tumor that invades into the serosa? Okay, so I'm going to end the polling there and share the results. Yes, so great job, everyone. It is PT4A. So for staging for gastric cancers, it's based on depth of invasion. So T1 is when it invades into the lamina propria, muscularis mucosa, or submucosa. T2 is then when it invades into the muscularis propria. T3 is when it invades into the soft tissue. T4A is when it invades into the serosa. And then T4B is when it invades into adjacent organs or structures. So for our case here, it's a T4A, so the serosa is actually involved. And you can see here that the serosa overlying the mass is dull and contains areas of kind of this white nodularity. As well, on cut surface, you can see that that mass goes all the way to that inked serosa there. So for regional lymph nodes, for N1, that's metastasis to 1 or 2 regional nodes. N2 is 3 to 6 regional node metastasis. And then N3 is broken down into A and B. So A is when there's 7 to 15 regional node metastasis. And then N3B is when there's 16 or more regional node metastasis. And here's an image here just showing all of those specific regional nodes for the stomach. And so another important thing to discuss when talking about regional nodes is the D2 or extended node dissection. So sometimes you can see on your requisition that maybe they've indicated that they've done a D2 lymph node removal or an extended node dissection. And sometimes you can even get suture orientation with your specimen. So I just wanted to take a moment to just describe these two. So D1 is the conservative node dissection, and that's the perigastric node. So these are stations 1 to 6, and that's shown with the blue circles here. And then D2 is the extended node dissection. So this is the extra perigastric node. So this includes D1 plus the removal of all of the nodes above the splenic artery, shown here. So this would include stations 7 to 12. And so a D2 lymph node dissection is standard in Japan for all of their gastrectomy specimens. And it's becoming more common in Western hospitals as well. It's important because this indicates that the spread of the disease, so if there's a positive node in one of the D2 nodes, then that means that the disease has spread to the next tier of lymph nodes. And also by removing these D2 lymph nodes, it can actually reduce the local regional recurrence of gastric cancer. So for distant metastasis, this is only required if confirmed pathologically in the case. And the most common sites of metastasis include the liver, peritoneum, lung, and bone. And I'll put up our next polling question here. So which of the following refers to an ovarian metastasis of gastric origin that is composed of mucin-secreting signet ring cells? Okay, so I'm going to end the polling there and share the results with you all. Yes, so great job, everyone. It is a Kirchenberg tumor. So these are the most common subtype of ovarian metastasis. These tumors represent about 5 to 10% of all ovarian tumors, and they make up 50% of all metastatic tumors to the ovary. The most common primary site for this tumor is the stomach, and this is a stage 4 disease, so the prognosis for this is pretty poor. And here's just an image just showing an example of one of these Kirchenberg tumors. So you can see intact ovary here, and then the cut surface of that metastatic tumor there. So we'll just finish off our talk by talking about the prognostic factors. So the most important prognostic factor is the depth of invasion and the extent of nodal and distant metastasis at the time of diagnosis. Ulcerated tumors typically have a worse prognosis than polyploid. Histological subtypes of adenocarcinoma, so diffuse type, also has a worse prognosis. And then the presence of perineural, lymphatic, and vasculature invasion is also associated with a worse prognosis. So thank you all for attending today's session.